This is Dr. Jerry Hesch. I am a orthopedic manual physical therapist at Hesch Institute in Aurora, Colorado. And I treat people, and I treat the nervous system, and I treat movement. And most of my clients have chronic pain that they've had for a long time, and they've had lots of interventions. My client Lauren is a physical therapist who has worked in a balance center for 3 years now. And she has a long history of facial neuralgia. And we don't know the source of it. You've had an extensive workup and nobody knows why you have that. But there is this strange connection to your upper neck. Can you explain that?
With my feet and
No, I'm talking about what you're aware of. You have treated it in the past.
So right now, the neuralgia will start, and it's this tingling or numbness that'll occur right on the right side of my face. And what I've noticed is if I treat my TMJ, and I do self-mobs, or I do manual massage to the masseters and the pterygoids.
The facial muscles.
Yeah, the facial muscles. It helps reduce it.
Good, keep talking.
Okay.
Keep talking.
Also, a few distractions, suboccipital distractions, will help relieve it momentarily, but it continues to keep coming back. So this is where I've come to Dr. Hesch, and he's found a few things.
Good. So sorry, missed a little bit, but yeah, you had mentioned that a professor would distract the OA joint.
Yes. So side bend, he would side bend my head and then rotate it and do an isolated suboccipital distraction to the right side.
Now, can you show me that position again, precisely?
So it's laying down.
Okay, go ahead. Go ahead.
I also have a video. I brought
That's
it.
okay.
Okay, so he would be on this side of me.
Okay.
And he would side bend me until he felt that OA.
To the right.
And then slight rotation.
Okay.
He would get his right in this middle part of the web of the thumb, and then do a distraction up towards kind of the nose up towards the head.
Alrighty.
And then he could do oscillations. So the moment he did that, the neuralgia was gone.
For how long?
For about only that day.
Okay.
But it was the best because I had been in that chronic pain constantly.
Alrighty.
And then now it's been a few years, it's been about 5 years, and it comes and goes.
So you haven't seen another PT for upper cervical
I have.
joint work?
I have, but it would not work.
What would they try to do with you?
Mostly suboccipital.
Okay.
Bilaterally. Nobody was really treating that area. And they didn't feel comfortable putting me in that position. So they were doing mostly upper extremity strengthening, a lot of postural re-education.
Okay, I got it. All right. So I'm going to tie in your ankles and your pelvis to your upper cervical. But what I want to do is put that in abeyance for now. And I just want to talk about what I find in the upper cervical. So if I come under the mastoid on both sides, okay, then I encounter the transverse process on the right quicker than on the left. So C1 acts like it's translated to the right a little bit. And when it rotates right, it does translate right a little bit, okay? If I try and spring it to the left, you can see there's a lot of resistance. If I try and spring it to the right, you can see there's that little bit of joint play, okay? Then if I come underneath it, so here's occiput, that's bony occiput, so I come up in here, and I should be on the transverse process on both sides, okay? I can easily induce a right rotation force, and on the right side, no. No such thing. If I come underneath that to what I believe is 2, we get free movement. Okay? So let me say that Atlas behaves as though it's stuck in right rotation with a little bit of side glide. Okay?
Okay.
Now I'm going to jump on the mastoid again. I'm on the front of the mastoid, and it's prominent on the right, so it's facing towards the ceiling. Okay? As though your head is rotated to the left. Okay, now I'm going to spring the left side, and you get that early tiny movement. So that joint play is through the OA joint, and it'll go beyond that. I get that. But it's that tiny little bit of spring mobility. And on the right, what happens? There's no movement. There is no, that little tiny initial spring is absent. Okay, if I come beneath the mastoid, and I'm going to lift up towards me, towards the crown of the head, okay, immediately I sense that it's lower on the right, and I'm going to do a little bit of spring. See that? You get that early first joint play on the left. On the right, what happens?
It's stuck.
I'm putting a lot of force. There's nothing happening. Okay? And if I try and spring obliquely, I discovered a pattern of restriction in the OA that is separate from this pattern. It's an additional oblique pattern. You have oblique motion on the left, but you don't have it on the right. We'll talk about that later. You may or may not have that oblique fixation. It could be occulted. But also, your transverse processes are encountered rather quickly, and that usually happens when someone is in hyperextension. It moves the atlas forward along with the head, with C1 a bit, you know, and I'm going to test traction of the upper cervical. So my contact has to be in front of the ear, and I don't get any traction. I can't get that little bit of play where you take up the slack. It's not there. And if I put your head in slight extension, if you'll scoot away from me slightly, right there, okay. So we drop your head back, okay, and again, there's no give whatsoever. But guess what? There's none here also. There's none there. So it's it's a little bit confusing. But we need to treat the pieces to make it whole. To figure it out, you have to treat asymmetry before you concern yourself with symmetry.
Okay.
Okay. And so after we restore motion in the things that we identified except for the traction, then we'll come back and we'll retest the traction and it might be there.
Okay.
You understand?
Yes, I do.
Okay, good. And then your jaw, again, you get some release of the neuralgia by doing internal jaw mob. Okay. I tested your jaw. I'm going to put you in slight extension, so hopefully your jaw just naturally opens a little bit. Just be relaxed. Just let gravity hold it open slightly. And so then I come underneath the angle of the mandible, and I'm just going to lift up with my index finger towards the ceiling. And that's nice. You got play. Your mandible is free to rotate left and free to rotate right. And if I take it all the way, I can still spring it. So far, so good. Come underneath it, and now I'm going to spring it upwards towards me. No give on either side.
On either side.
So you're very compressed in your jaw. Very vertical compression. So we need to treat that. Now, I need to tie in the ankle and the pelvis. And there's a reflex in the body called the righting reflex. You cannot overcome that reflex. You have to work with it. But what I found is that in your ankles, you only dorsiflex to about +5, and then if I try and spring it, it's real tight. And same thing if I just contact the talus here and try and spring it posteriorly, it's very, very tight. And that's on both sides, okay? That might inhibit some strength. You want to pull your toes up and your feet up towards you. Show me how strong you are. Pull up really hard. Keep pulling, keep pulling. Good, you're fine. All right. But this will shift your center of mass anteriorly. Okay, so it's a bit like you stepping into some high heels. And you know what that does for you.
Well, I feel the most comfortable in my feet when I'm in high heels.
Ah!
You saw the boots? Those are the
Got it.
only ones that I've been able to. It has a little bit of that heel, and that's how I get through the day at work. I put some little shoe lifts. I know it's horrible.
No, it takes your body, it lets your body catch up to your ankles.
But going barefoot is the worst thing I can do right now.
Okay. Okay.
Absolutely, it's horrible.
Okay.
So, I know it's all tied.
So that shifts your center mass forward, And in response to it being shifted forward, you kind of flex. In the lumbosacral region, you flex, but then you hyperextend in the interscapular area and then in the atlantoaxial. I'm sorry, yeah, AA,
yes.
yeah, AA, C1, C2 joint. And that's reflex. So that if we restore motion in that ankle on both sides, then the neck may soften and that traction might be restored, that traction mobility in the neck. Now, the pelvis is also quite restricted on both sides. They call this bilateral anterior ilium. I don't like that terminology. I'd rather go with anterior tilt, okay? Anterior pelvic tilt. But this is a treatable one, all right? And you don't have any posterior spring mobility on either side, okay? And that also is shifting your center of mass anteriorly relative to your body type. Everything I test in the rest of your body tells me you should have spring mobility here, and you don't. Can you line your stomach? So you have good vertical mobility, translation, okay, and on both sides, and you have good rotational force translation, mobility, but not this direction, not this direction, okay? So I don't blame this on the sacroiliac joint. Okay, it's part of a whole complex system, right? I just know how to find it and treat it, and we can debate till the cows come home and not be productive. So how about if I treat you?
Yes.
Okay, can you lie on your back? So my treatment should be a one-time intervention, and I shouldn't have to do the treatment again. And on the second day I teach you how to keep everything I did with you. I expect you to walk in the door tomorrow and still have all of this mobility that we gained today. All right? So in terms of the ankles, I just do a scoop on the calcaneus up towards the ceiling, and then I just oscillate firmly. And then I come up to the tibia, make sure it springs posteriorly. It does. All of a sudden we have a lot more ankle motion. Okay? And now every time you walk, those ankles are going to find more motion, just naturally, so it just reinforces itself. Okay? So now I'm going to work on restoring pelvic motion. And bend your leg there. Come close to me, please. All right, good. Lift your bum up. Lift your bottom up. Yep, come down. Good. All righty. So I just do an oblique oscillatory mobilization. And then I do a very gentle, soft tissue. You know, just relax. Just relax. I'll do that. Just take it very gently towards end range. And then I'll just give it 10 oscillations. Okay. And the knee to the outside of the shoulder is so much better than knee to chest. Yes. Yeah. Good. And we have mobility now. Yeah. Okay. So I'll restore the other side. And I know that I'll have to work on the upper neck. Okay, let's lift your bottom up. Come down on my hand. Good. And so we do treat it from a biomechanical perspective. I'm treating it, you know, obliquely. But we've learned a lot, and we have to be careful about blaming asymmetry of the pelvis or asymmetrical movement on the SI joint, because it's too complex a system to just blame it on one joint that moves only a tiny little bit. And whether or not we can extract information from that joint or not is, you know, we don't know that, except in extremes. All right, well, just go ahead and take a walk. Just walk halfway down the hall and come back, and then come sit in the chair and tell us how you feel.
this feels really good. So when I walked in, I had a lot of pain down into this area. I don't feel it at all.
Uh-huh.
I feel a little just soreness in my ankles.
Okay.
Just in the arch.
Okay.
But not where I have it usually on the lateral part. So I just feel it in the archway.
Okay. Did the mechanics of the ankle feel different?
I feel it looser. I can like move. And something
Sorry?
that my husband was watching, I started kind of internally rotating my toes and
Oh.
because it would help with pain. I don't feel that now. I feel like I have good out toe.
Out toe. Great.
Yeah.
Great. Well, good. Try sitting. So you could be weight bearing on a different part of the ischial tuberosity. Could be subtle. Your thoughts?
Actually, I'm not sitting on the bony prominences anymore.
Nice.
Actually, I have some cushion.
Nice. Excellent. Good. Okay, come on your back and let's go to work on your upper
Oh,
cervical.
that's interesting.
All right. So, I'm not sure it matters which structure you treat first, but I'm going to choose to treat the occiput first, okay? And you still present with that same pattern that you had. And so what I'm going to do is I'm going to take my index and middle finger and I'm going to scoop underneath left to right. And actually I'm using my ring finger also. I am blocking everything underneath the occiput. So probably blocking the transverse processes lamina of C1, 2, and 3.
Okay.
Then I'm going to side bend you to the left about, you know, maybe 5 degrees, maybe less. And then I'm going to just rotate your head into my hand, into my fingers. Everything is locked up now. Okay? So we're inducing left side bending. We're blocking C1, C2, C3. And now I'm inducing right rotation of occiput. And I'm just going to walk it over there very slowly. Just give it little tiny oscillations. Alrighty, so that was about 20. And now I'm going to come on top and the tone feels better. I can get that little tiny spring there. Okay, come underneath it, I can get that little tiny side bending spring. Okay, and I'm going to now do an oblique spring at a 45-degree angle, and you have that motion also. Okay, so now we come back to C1. C1 is still glided over to the right, still rotated over to the right. So I want to now rotate C1 to the left. Okay, so what I do is with my index finger, I come to the occiput and I lift up under C1 on both sides. Then I'm going to move index and middle finger below on the left. So I'm going to block C2 and C3. And I'm going to side bend your head to the right, open up a little bit of space, and then I will just be oscillating C1 to the right. Very different than the muscle energy technique. I certainly like this a lot better. Okay, so I'm blocking C1 and 2, just kind of lifting up. Maybe I have 5 pounds of force, you know, through each finger. And same thing at 1. And then I'm just doing 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We'll do 10 more. Okay, and then I'll come back, and now I'm under C1, right where I was working, and now I can get that little tiny rotation there. See that? Okay, so we can glide it now. That's happier. Okay, could you walk down the hall halfway and come back and sit down and tell us how you feel?
All foot pain's completely gone.
The what?
The foot pain's completely gone.
The foot pain's gone. Okay.
Pelvis is great. It's a lot looser.
Okay.
Just a little weird sensation on the face.
Okay, alrighty. We still have jaw to go, so let's have you lie on your back. So now that we have symmetry of C1 and occiput, then now I'm going to concern myself with that traction one more time. So I want you to scoot down a little bit. One more little scoot. Okay, right there. So in neutral, I'm going to do traction, which has to be on the temples to go to the upper cervical. All the other facet joints are in the back. All right, so I can take up some slack there. Okay, and then I can give it a little spring. I see the force go all the way down to your feet. That's about 10 pounds of force. Okay, I'll test it in flexion. Nice. And I'll test it in extension. Beautiful.
It is.
Yeah, a lot better.
Yeah, a lot
so
better.
now we need to treat the jaw. Okay. So what I want to do is put your head in about 5 degrees of extension. I want you to relax. And all that I'm going to do is come in front of the lobe of the ear because that's below the joint. I'm going to capture the mandible on both sides. So I'm going to come capture it with little finger and a little bit of ring finger, and I'm just going to track them straight down towards my fingertips, my middle fingertips. And I'm going to do that for 3 minutes. Okay? So I'll show on the skeletal model that the joint is right here. That's the disc right there. So I want to be below that, and I'm just contacting the flat part and just pushing straight downward. So I'll stop filming, I'll set a timer, we'll do it for 3 minutes, and then we'll come check the response to that. And less is more. It is the most gentle thing you could experience. It is measured like 3 pounds of force on each side. The body loves it.